I'm an adult endocrinologist in St. Paul, Minnesota, and by definition, we practice bariatric endocrinology. The premise behind that is that the adipose tissue is an endocrine tissue, the adipocyte is an endocrine cell, and derangements of function and structure of the adipocyte and adipose tissue contribute to metabolic disorders. So the goal of our practice is to return adipose tissue function to normal as a means to return metabolism to normal. It's been a lot of fun to do that. We've been at the Minnesota Center for Obesity, Metabolism, and Endocrinology for 18 years now. So only independent endocrinologists in St. Paul as of right now. And I guess both of you are in academic practice, right? Disha, Nisha?
I am Disha Narang. I am an endocrinologist and I work for Northwestern Medicine. And so I work at an affiliate hospital of Northwestern Memorial, which is Lake Forest Hospital. And so we are semi-academic, and I am currently leading the efforts to grow our obesity program. And so we are in the process of just sort of creating an interdisciplinary effort to bring, obesity medicine to our hospital. Obviously, through my practice as an endocrinologist, I'm doing a lot of weight management and obesity medicine. And currently, I'm also getting my licensure in culinary medicine.
Awesome. So I'm Nisha Patel. I am an internal medicine physician here in San Francisco, and I work at it's a semi-academic center as well. We have trainees, and we also are a transplant center. So I technically work for the Department of Transplant. I actually, Disha and I recently became board certified in obesity medicine, and it's been a huge passion of ours, really raising awareness in our communities and amongst our colleagues about what is obesity medicine and understanding that obesity is a chronic disease. And so I spend a lot of my efforts educating my colleagues and also bringing awareness and trying to bring that presence to my institution. I am also pursuing a certification in culinary medicine through a program called Health Meets Food. It's the same one that Disha's pursuing her certification through. And I think that goes so hand in hand with what we advocate for in obesity medicine is really the lifestyle is such a foundation of the treatment that we have for our patients, and teaching them practical skills to make those healthful eating habits for their entire life is crucial. So I love, I love spreading awareness. I love educating my colleagues and others and my community, and it's been really fun.
I'm just delighted that there's more of us now, because it has really been hard work to get colleagues to understand that obesity is a treatable disease.
Absolutely. I think one of the biggest pushes, and this is sort of more nationally as well, it needs to be recognized as a chronic disease, because otherwise, our coverage for medical weight management and all the resources that we have towards that, it's just so poorly covered. It's better, obviously, than it was maybe 5 or 10 years ago, but I feel like that is such a rate limiting step in order to treat our patients appropriately.
I wholeheartedly agree. I mean, I've encountered colleagues of mine that, when we talk about the medications that are approved for the treatment of obesity, it's always like, oh, why would you put somebody on medications? And it's like, well, we don't hesitate to put others on medications for their high blood pressure or their diabetes or their high cholesterol. And this really shouldn't be seen any differently. And so I totally agree with what you said, Disha, that like if part of the hurdle is getting awareness out there and getting that understanding out there amongst our colleagues, because I see a large population of patients with NAFLD and NASH cirrhosis and that interim fibrosis, where you can actually intervene and help patients reverse them from progressing to end-stage liver failure. And we are, we're a transplant center, and we just see, I mean, I can't tell you how many patients I take care of that have NASH cirrhosis. And I always wonder, if we could have used all of our tools in the toolbox. They probably weren't available when, these individuals were diagnosed many, many years ago, perhaps. But I think it's just, it's using all the tools in the toolbox, just like we would for any other disease.
It highlights that prevention is really important in dealing with every chronic disease, and
absolutely
stages of prevention, right? So you can prevent cardiovascular events by treating cardiovascular risk factors, but then the risk factors for those risk factors are the weight and the insulin resistance and
Absolutely.
dysmetabolic
Yes.
syndrome.
And, I think there's such a stigma still surrounding medical weight management, right? Because a lot of even fellow physicians think that medications to aid with weight loss are, sort of the run of the mill diet pills, especially, patients and physicians alike. And so I think a lot of my job, I feel like I have to sort of dispel these myths that, oh no, we're not some sort of spa that gives, fancy supplements and diet pills and things like that. Like, this is a chronic illness that I would expect someone to be on treatment for at least the foreseeable future, if not longer.
And I think it's helping patients understand that, our social media and society, they always focus on the one thing, the number on the scale. And it's way more than that when it comes to obesity management. That's a metric that we obviously track in our patients, but, we are trying to reverse, or improve insulin resistance. We're trying to get down to the root causes of what's causing inflammation in our body, what's leading to cardiovascular disease. And when I talk to patients and I explain it like that and say, look, it's not, everyone's out there like, oh, weight loss this and weight loss pill that, but that's not what we're trying to do. We're trying to improve your life. We're trying to prevent comorbidities from developing. And this is how we're going to do it. We're going to use medications when we need them. We're going to always emphasize a healthful lifestyle. And that's going to be no matter what stage of life any individual is at. From being a child to all the way to older age. I think it's just so important.
Disha, you had mentioned that you're working to create a multi-specialty practice. Tell me about that. What are you guys doing?
Yeah, it's sort of kind of come up over the last few years. And so there's definitely a greater interest just system-wide to really embrace obesity management. And so, right now, we're actually hoping to get a bariatric surgeon on board. We unfortunately lost our other bariatric surgeon just in the last 6 months. And so right now we have a strong referral network within Northwestern towards downtown and one of our other satellite hospitals, but we're ready to engage, GI, obviously endocrinology, have a huge primary care foundation as well, just because and I'm sure, you experience this as well. I'm booked out about 7 months at this point. And so to be able to get adequate continuity of care and get patients in and worked up and everything, it's a huge rate limiting step, especially because there is such a shortage of endocrinologists, as you know. And so we are trying to really create a large primary care base to be able to identify patients early, get in early, get them engaged and, part of a program. And so, Dr. Kushner is actually sort of the same mindset, just because they are so booked out right now, and it's just there's not enough people. And so I think, with obesity medicine, it's kind of like more the merrier, just because this touches every single specialty. And so there's an emphasis on cardiometabolic. So we've got cardiology invested in this as well. And so, I think this is why it is so important to, as an institution, embrace obesity management, just because this literally touches every single specialty. And so I'm excited. I think there's a lot of possibilities here and a lot of hands on deck. And so I think, there's a lot of potential for us to grow. And there's certainly a demand, just because unfortunately the population is not necessarily getting lighter, unfortunately, so.
It's interesting to hear that in most healthcare systems, the bariatric center is kind of structured around bariatric surgery. We actually design our practice to be the antithesis of that. We view our job as doing everything we can to keep patients away from the surgeons. And you'd be surprised when you approach obesity as a chronic disease, when you think beyond the pounds in the scale, like you were saying, and you educate patients in the process. We can achieve surgical weight loss by approaching obesity the same way we approach other diseases. So
absolutely,
we start with monotherapy, we go to combination therapy, and we're adding agents to bring the weight down while we continue to focus on the nutrition, the physical activity.
Absolutely. And, I think some of the agents that are, especially now more recently available, we're getting weight loss to the degree of a gastric sleeve procedure. And, I'm having patients come in with 50, 75 plus pounds weight loss, but the crux of that is still lifestyle, right? And so any of these medical weight management agents are just simply resources to weight loss, but it really takes a team. And I always sort of tell my patients that I'm their cheerleader, or our dietitians are their cheerleaders, keeping them going through that journey. So Nisha, sorry, you were going to say something.
Oh, no, I was just saying that going back to what you're saying about, kind of building that like medical weight management presence at your institution. And I know that our institution and our medical group's been really trying to build towards a metabolic clinic and working with, and it's taken years. And I think that kind of just speaks to the fact that, the people are there, but to get your institution on board, that's a challenge, to get their support and get them to be where you are as far as understanding and advocating. And so I think I'm hoping to be a part of growing that metabolic, we're calling it a metabolic clinic, but it's to help our patients with obesity and multiple other chronic diseases achieve, better health. And so I think that I'm hoping to see more centers, really incorporate a medical obesity weight management clinic or practice into their healthcare as well. But like you said,
I invite you to think of yourself as a bariatric endocrinologist, to advertise your practice as such. And when we're done with the conference, if Katie allows it, I'll share with you a publication that we have that kind of puts it all together. It's a textbook of bariatric endocrinology, but
I'd love to see it.
we'll share it with you guys. But there's some things that are kind of fun to talk about with colleagues. And Bob Kushner and I, this was back in 2013 already. I was the principal author, and he was one of the co-authors. Took the time to review the world literature on nutrition and dietary interventions for chronic disease management. So we published with ACE and the Obesity Society the first ever reference graded, reference based healthy eating clinical practice guideline. And one of the themes that goes in there is that we wanted to eliminate the word diet because diets don't work.
Well, diet means way of life, and it wasn't meant to be like the way.
And I feel like the U.S. in our culture, diet has become it's almost like a toxic word, right? Because it's almost like people think about restriction the second you say the word diet.
So that's why it's music to my ears to hear you guys talking, because you're talking about health, wellness, culinary medicine, and so we tell our patients, listen. Going on a diet is the wrong approach. You're asking the question, what can't I eat? And the question to ask instead is, what should I eat to provide myself with the nourishment that I need in a healthy way? And the same way, we kind of called for us to avoid the word exercise, because it also doesn't work. If you ask a 300-something pounder to go exercise, you could kill them or give them orthopedic injuries. But physical activity that we build into our daily routines is incredibly important. So the concept of wellness that you were talking about is huge. And that's what we really focus with our patients. But pharmacotherapy definitely plays a role in this chronic disease.
It definitely
does with other chronic diseases.
And the way that I usually think about potentially adding medical weight loss agents is that, as we lose weight via, whatever it may be, dietary patterns, exercise, whatever it may be, just lifestyle changes, our ghrelin, our hunger hormones are going way up. And so our bodies are sort of programmed to regain that weight that we lose, right? And that's why I think that these medical weight loss agents do become so useful, because it helps to enhance that effort without your body's hormones telling you, no, you need to keep eating, because I'm hungry. And so I think that just, being that I practice obesity medicine, I think that is so fascinating, just as an endocrinologist, but also looking at the physiology, because it's not truly I feel like a lot of patients come into my clinic feeling shamed and judged for sort of their weight and just their whole life, right? And we just don't know what their background is. We don't know what their family genetics are. We don't know if there's a secondary cause for weight loss. Do they have Cushing's, whatever it may be. But it really comes down to the physiology here, and that's where I think the blame game really doesn't work in obesity medicine, and using medications to then enhance an already conducive lifestyle. That's where you see all those results, and that's the most satisfying thing, I think, as a clinician.
I think I try to explain to patients and like colleagues that, when you're going through weight loss, it's like your body is literally just trying to fight it. And how can you continue working against that? And we can't, right? And people get demoralized, they get discouraged, and they don't feel like their efforts that they've put in to achieve their health goals to that point mean anything. And I say, well, we wouldn't let somebody who's like blood pressure just stalled at 160/80 on one agent just sit there like that, would we? We wouldn't. We would optimize them and use medications and continuing with lifestyle changes. And so I think it's just giving them that framework and that mind, that foundation is so important.
The challenge about that is the obstacles that we have to overcome. And you touched a little bit on a couple of them. We don't get coverage for medications.
Yeah.
That's a big one. But I think that there's other challenges that we probably could, spend hours talking about. I'm just curious, in your practices, how do you refer to your patients? Because that stigmatization of obesity as a disease, or, it's your fault that you have this, if you just get your act together kind of an attitude that is out there, is still very prevalent. So how do you approach your patients, and then how do you approach your colleagues to educate them about how things really are? You mentioned the biology, which is right on, but how do you tell patients, hey, you've got a chronic disease, we've got to treat it? So just want to pitch in. I want to hear what you guys have to say.
That's a really good question, because I feel like by the time patients do get referred to me, they know that it is for weight management a lot of the time. Or, I'm sure you see this as endocrine as well. A lot of people come in thinking that weight gain is secondary to their thyroid disease, or, something hormonal or postmenopausal weight gain. And so I feel like that stigma, I don't necessarily deal with it as much. I have a feeling primary care sees it a lot more than I do, because they sort of know what I'm going to be talking about, and they're ready for that conversation when they see me. And Nisha, I'm not sure if you have a different experience.
Yeah, I think whenever I talk to my patients about their illnesses or their health, I right off the bat will say that, look, you have you have diabetes, and I see this a lot: diabetes, heart disease, and I do see, like I said, a lot of non-alcoholic fatty liver disease, and I say, all of this is tied together with the chronic disease of obesity, and I'm very clear when I say that, and I tell patients that, look, this is like a disease like any other disease. I don't really, I know social media or like society has told you that it's all about your weight and that you gained weight and it's because you ate too many calories. And I really spend that time educating them and saying, look, it's way, that's like, first, that's wrong. And then B, that would be way of an oversimplification on an explanation of why you have obesity. And so whenever I kind of take it off their plate of like, this is something they did to themselves, it becomes an easier conversation. And it, it takes multiple conversations, and I just, it's unfortunate, they probably, maybe they've grown up in a society or a family or a neighborhood or an environment where people have constantly blamed them, and it's hard to get out of that mindset. But taking it off their plate and saying like, look, we're going to treat this like we treat your diabetes, and we're going to treat this like we're going to treat your heart disease. It becomes a different kind of mindset and conversation for them.
And the unfortunate part is, by the time that they do present to these situations, I mean, when Nisha sees patients, like they're already dealing with a lot of the chronic illnesses. Same here with diabetes. But there's been so much of a mental play already that whether it's depression or stress or whatever that may be that potentially drives certain behaviors, that's, I think, one of the biggest challenges is to break through some of these mental barriers to allow them to embrace various lifestyle changes that may be conducive to weight loss. And I think that's why it is so important to, not just write it off as like, oh, well, maybe you should eat healthy and exercise. I think that's just one of the most patronizing things that you can say to a patient, because they're coming in with a lifetime worth of, the buildup to this, right? And all the consequences of it and the social stigma of it, everything. And it's just so important to address the mental health part of this.
So
I think, oh, sorry, go ahead.
no, I was just going to agree with both of you. I think that our practices are probably a little different because our patients do have that readiness for change that comes with diagnoses that are complications from overweight and obesity. It's a little different than a primary care setting, but all of us have the same challenge of first identifying a problem, creating awareness of the problem, and then enabling patients to seek solutions to that problem. So I'm going to share with you that when we see patients in the clinic for the first time, everybody gets treated the same. We do the same for everybody at every visit. We get their height, their weight circumference, we calculate their BMI. And then when we sit down with them, we tell them, you are not obese. And then I always have that pause, they're like
What?
And then they look down and I go, well, what do you mean I'm not obese? Everybody says, I said, no, because if I say you are obese, then obese is who you are and you're not your disease. So rather, you're a person who has obesity, which is no different. A person who has appendicitis, their diseases because they take away from your health. And just like we treat appendicitis, we're going to treat your weight. So as simple
I love
as
that.
I love that.
So it's actually, a message that patients do take well and that I'm trying to teach my colleagues to deliver. When we say you're diabetic, you're obese, you're depressed, we're really continuing that stigma that they're kind of shying away from.
That label.
But you have a disease, we're going to treat the disease is something that, pretty much everybody's open to.
Yeah, I mean, the people first language, like I see it in our, on our charts. I'm sure you see it too when you are having people come from different providers and it's like 69-year-old obese male, female, whatever. And it, you're just like, oh gosh, because with 69-year-old obese female with diabetes. And so I think it's like changing the mindset and saying, no, this is a 69-year-old female and they have obesity, diabetes, not that they are obese. I love that.
One of my typical patients is a postmenopausal woman. It's just a very common patient type that I see. And oftentimes, and I know, Nisha and I have talked about this before, they're often the nutrition gatekeeper of the family. Yeah. And so usually that empowers them to be able to make changes for themselves and their families rather than being dependent on somebody else. And so I think giving them that tool that, hey, you're in charge of this, you're in control of this, and you can make this change for the better for everybody. And so they get really inspired that like, oh my gosh, like I can really change the health of my overall family by just making some of these minor changes. And it's just a little tools like that. I don't know, call it motivational interviewing or whatever that may be, but I do think that helps to really sort of give them the tools to take one step further in that journey.
And definitely use motivational interviewing techniques when we're trying to get to the bottom of like what they're actually doing in their day-to-day lives and what activity means. And I want them to come to that realization versus me being like, okay, you did this, And so I think, Disha and I definitely, we're not the best at motivational interviewing, but we practice it. I think it's useful. And I love that term, nutrition gatekeeper, Disha. Like a lot of our patients are the nutrition gatekeepers for their household. And I think just giving them that empowerment and saying like, look, you have you can make such a big impact for your entire household. And they don't see it that way until you point it out sometimes.
So I love everything that you two just said. I'm in love with both of you. So
We
listen,
love obesity
these,
medicine talking about food.
these words are music to my ears. So when we have patients like that, the first thing that I do is I take a step back and say, okay, let's take a look at the big picture. You've been working with us for so many months or so many years, and when you first joined us, this was your weight on the scale. And the weight on the scale is the magic thing for them. So our goal at the time was for you not to gain, for you to start losing. Just maintained. You didn't keep gaining. That already would have been a benefit to you. But we gave you a benchmark to lose 5 to 10% of your weight. And most of these patients are going to lose at least 5% of their weight. That's easy to do. I mean, everybody loses 5% of their weight. But then they plateau. And that's where the frustration comes in. So, you start by telling them, you've already made some progress, compared to where you were. You've already gotten down here, and you have awareness, you're keeping your appointments, you're taking the medications, you're creating opportunities for intervention. But then the other thing that I started thinking is, what's getting in the way? And what frequently gets in the way is the things that we don't think about frequently, but we have to think about it. So you just recently get some steroid shots for your bad back or your knees. Did you, develop Cushing's syndrome? We've had 2 Cushing's disease patients in our practice within the last couple of years, both of which just all of a sudden, just stopped losing weight, and then they just started regaining. And over time, they developed the plethora of Cushing's disease. And you go, wow, we screened you for this at the beginning of your intake visit with us here. You didn't have it then, but you've developed it. Now you have it, and that's an obstacle. And for sure, it's not just the lack of estrogen with hypogonadism, it's the lack of testosterone for women. We don't even think about testosterone replacement in women. The women are walking around with unmeasurably low testosterone levels after their change of life. And without testosterone, they lose their strength, their stamina, their endurance. They promote the accumulation of fat in the middle, and they're tired and they're depressed. So we replace testosterone in postmenopausal women, just like we replace the estrogen. So all of those things factor in. But at the end of the day, all of these patients that have reached the plateau, the one thing that you want to really educate them about is that it's not for lack of trying. It's the biology that is wired into us that is responsible for this. The biology that led you to gain weight to begin with has revved up as you started to lose the weight. So your biological adaptation to that weight loss is you're hungry, you're less full, you're not burning as many calories just sitting there. You've reached your plateau. We're going to have to work harder to overcome that if we need to continue to go down. And we need to recruit more pharmacology to help you with that. So, being an ally, I feel your pain. I understand what you're going through. We're going to find solutions, is what they want to hear. They're absolutely right. They don't want to hear, boy, you're lying to me.
Or like, I think the one other thing that comes up are people, I hate when people say this, honestly, is eat less, move more. And I think a lot of my patients, I'm sure Nisha, you've seen them, have said,
they know that. Yeah.
Somebody say that to them. And you're just like, what? But again, yes, being an ally, being on their, we're in the back seat, they're the driver of the car. We are there to guide them and empower them and help them.
So that concept that they're the patient, but they really are not operating in a vacuum. They have to recruit their support structures, both at home, at work, in the clinic, is really, really, really important. Every one of those patients is a catalyst for change in their family. Yeah. So if it becomes a home health and wellness program, not an individual health and wellness program,
even better.
It's easier for them, the family benefits. And boy, that really makes a big difference. So we ask them when they come to the dietitian visits or the nurse educator visits, bring who you live with you, so that there's 2 of you doing this together. And that really does make a difference at the end of the day.
It's a win-win situation for both of them. Yeah.